Hi, I'm Mina Malik Hussain, and this is The Coffee Table. As you know, I'm sure, that September is an International Suicide Awareness and Prevention Month, and every September we like to have a show where we talk about suicide and depression and mental health issues and try to create a conversation that serves as a support and an awareness building exercise, so that if you are watching this and you feel like any of this is familiar, if you are somebody who knows somebody who needs help, this show might be a springboard to help out in some small way. So I am very, very happy to be welcoming today with me two very accomplished therapists who are going to have a really instructive and informative conversation with me about the issue. So joining me today on set physically is Maryam Suheyl, who is a marriage and family therapist, and Fatima Hashmi, who's joining us all the way from Chicago, who is a clinical counselor specializing in chronic trauma. Hi, welcome to the show, Maryam and Fatima, from, a distance. It's lovely to see both of you. Thank you so much for taking out to have a really really important and really vital and crucial conversation. So Maryam, a lot of your practice, all of your practice is in Pakistan and in Lahore. Yes. So when we're sort of talking about suicide, then what is an appropriate place to start the conversation?
I think the first place is to start thinking about the myths around suicide, right? Because I think suicide as a topic is a bit scary.
Yeah.
So, and it hasn't been explored that openly. So it has a lot of myths around it.
Quite right. And there's also a lot of cultural taboo around it as well. And just, I think generally the idea of a friend or a loved one or anyone that you care about feeling like this is, I think, scary.
It's very scary
to contemplate.
Absolutely, absolutely. And that is one of the biggest hurdles of the patient, of the person who is struggling with that,
It's terrifying for them also.
For them also, and then to see that terror just, ripple in the entire system, that is also, that keeps one from even talking about their feelings authentically, right? So I think the first place for us is to start really debunking some of the myths that surround this topic.
Right.
And one of them is that if we speak about it, it will happen. Right? That we'll encourage the person. If we openly talk about it, that, okay, do you have a plan? When do you want to do it? All those things.
Right.
It will encourage them to do it, which is not true. It is already in their head. It'll probably just help them see the absurdity in that, or probably will just help them see that maybe there are things that are worth living for, right?
Right.
So first...
and kind of flesh out the reality of taking a step like that, where you it's not an idea. When you kind of see it as a concrete thing, then you might be like, oh, I don't like the sound of that.
Right, right. And then you have an ally.
Yeah.
Because mostly people who are suicidal really keep those thoughts to themselves, right? And it keeps other people from helping them. Right? So if they're given that space to openly talk about whatever and how gruesome that ideation is, I think that can be helpful as a first step.
Right. Okay. So Fatima, you are practicing in the United States right now, yes?
Yes.
Yeah. So I was reading statistics, and 1 in 5 Americans is depressed. And there is a link with depression and suicide as well. So, and I feel like depression generally in the world is, do you think it's on a rise, or is it just that it's diagnosed more?
I think it's a combination of both. Because now we have more awareness around what suicidality looks like. I think Maryam made a very valid point of, this is a conversation we didn't have typically very often before.
Yes.
But now we're actually making this a screening process. In the United States, anywhere you go, whether it's a primary care physician, whether you're seeing a therapist for the first time, you immediately have a screening process where we discuss suicidal ideation. Have you ever thought about taking your life? If so, how long has this been going on for? Do you have a plan? Like, have you thought about how you would carry that through? And then there are systems in place where if the person says yes, then we have a whole system of how we go about supporting them in that process. And the immediate thing to assess is there a risk of this happening right now, immediately?
Okay.
Yeah, like, are they going to go home after speaking with me today and going to do something. That is a thought process that we have to be aware of as well. And I think the more we normalize this process in the sense of this is common. Like we often think about, wouldn't it be easy if I could just end it all? Or I'm under so much pressure right now. Wouldn't it be easy to just get out of this mess and just end my suffering? This is a thought process we've all experienced at some point in our lives. The only difference is we have managed to overcome that thought process. But for those people, they may have stayed in that thought process for a very long time, even years.
So why do you think that some people are able to kind of move past the idea, and for them it might be a fleeting thought, and some people stay with it longer? Like, is it because of other mental health issues?
I think it's a very contextual thing, because it's also about their support system. It's also about their upbringing. It's also about their immediate system, their schooling system, their family system. Were they ever taught the skills and tools to handle overwhelming emotions and challenges in life? Or were they in an environment where they were either neglected or overprotected, that they could not even handle something like, maybe it's having a fight with a friend, which can cause someone significant distress. Maybe they never had those coping mechanisms and tools that were established early on in life. That's why therapy is so crucial, because that's where we build some of those skills.
Yeah, and we're able to kind of act those learned traumas of the past. So this is actually, it's a really incredibly complex issue that we are dealing with. And if we're looking at parenting, and we're looking at family systems, and we're looking at schooling, and I feel like that's a really interesting point that Fatma's made, is that there are so many factors that go into it. And do you feel like culturally, are we kind of better or worse off than maybe other countries for this? Because we have a lot of cultural approaches to things as well, like handling emotion, for example.
Yes. Maybe we do have a lot more resources, in terms of support, and maybe we are not as isolated.
Okay.
But at the same time, I don't think there's very little awareness and compassion in our society for mental health, for somebody who's struggling with mental suicide or otherwise, even anxiety.
Yes.
Kids are picked on. The ones who are anxious are picked on in schools, right?
Yes,
so,
absolutely.
I think that is where we lack a lot. We don't have compassion for this. Awareness is not as much true, but I see a lot of other cultures, and they're very compassionate towards disability, towards mental health, right? And we're yet to develop that, I think.
And in spite of a general shift towards more people go to therapy now than maybe 15 or 20 years ago, and there is still some conversation sort of opening up
much better.
About it.
I came back to Pakistan in 2011, right? And there was nobody that was willing to come to therapy, or especially process-based therapy, right?
Yeah. What is that?
A process-based therapy is where you talk about feelings and emotions.
Right.
Versus when you are having like a complete psychotic breakdown, and you're taken to a hospital, and the doctor then, recommends that you should also seek therapy. Which is a different kind of rehabilitation kind of work,
So it's a very important distinction to make also, is that the kind of traditional idea of mental illness that we have, there are different kinds of it. So
absolutely,
every mental illness is not a psychotic break that requires medication or institutionalization.
Absolutely.
You have a lot of other things like anxiety or depression, or I'm sure other things that I don't know in that category, which require therapy, and that's a different process.
Absolutely.
Altogether.
Initially, I wasn't getting those clients, right?
Yeah.
I was only getting clients from psychiatrists' offices who were mostly, dealing with some kind of a very severe form of mental health issue, either a psychotic break or some kind of depression, which was very, 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 very clinical, right?
Right.
And it demands a very different kind of clinical approach and treatment approach, right?
Yeah.
Than just talk therapy. while the rest of the nation was suffering from a lot other forms of mental illnesses that were just, behind a veil.
Right.
So that veil has been lifted, for sure. And then the trend came up, people started to recognize that they needed to speak up about their feelings.
Yeah.
And they felt better afterwards.
Quite right.
In Pakistan right now, therapy is a very expensive commodity.
Yes.
Right?
Yes.
But more and more people started to invest in that because they felt better after visiting a therapist.
Yeah.
And
it's like a clear change. You feel a clear difference.
Absolutely. And students, who are just saving away their pocket monies, they are coming to therapy.
Wow. Good for students, like young people. Yay. Well done. Yeah, that's fantastic.
I mean, that's a change. That's a change I have seen in like last 8 to 10 years for sure.
That's very promising, and I feel like a lot of the times with undiagnosed mental issues is that you are feeling something, but you don't even know what you're feeling. You just know that it's bad. Like anxiety, for example, like you feel nervous.
Yeah.
But like it's actually anxiety, and that's not quite the same as nervousness.
Or that you're just shy.
Yeah.
Or you're just, socially awkward. It's not the same.
Yeah, exactly. And I feel like that terminology and like understanding it makes a massive difference. Okay, we're going to take a very quick break and come back to this conversation. Stay with us. Hi, welcome back to the coffee table. We're having a very, very important conversation about mental health and suicide today on the coffee table, and we are talking to therapists Maryam, Suheyl and Fatima Hashmi about it. So Fatima, tell me, according to some statistics that I've seen, there is an incredibly high correlation between suicide fatalities having depression or some other diagnosable mental illness. So it seems like depression has a major role to play in somebody who does go ahead with suicide.
They say about 80 to 90% of cases where suicidality has occurred, typically there is a history of mental illness. And that can be either persistent depression. That means depression that's been happening for a series of years. That's what we call dysthymia, because it's been happening over such a long period of time. But you can still function as a normal human being despite having dysthymia. So that's why that becomes a bit harder to detect. But then there's more chronic mental illness where that becomes a bit easier to identify, such as schizophrenia, bipolar disorder, significant anxiety. Those are easier to sort of pinpoint and go like, okay, so if this person has this mental illness, there's a high chance or possibility that they're also experiencing some level of suicidal ideation. It's also important to point out that there are certain cases where there is no prior mental illness after suicidality has occurred.
Right.
So not all suicidal cases will have a prior history of mental illness. Sometimes it's just about impulsivity, not having any control over your impulses, and you just want that suffering to end so badly that your impulses sort of take the driver's wheel and they push it all the way through.
That's very alarming, I think, because again, it sort of harks back to our kind of stereotypical ideas of what an unhappy person looks like, and you can be a very high functioning person with depression, but generally speaking, what are signs that somebody is experiencing a kind of long-term chronic depression?
Depression.
Or / mental health
issue.
Issue.
Yeah. So there are, first of all, any kind of change in the person's character is an indication that they're suffering, right? Especially, for example, if somebody has been angry all their lives, that's the way they relate to people, right? So it is not necessarily a mental illness.
Yeah, it's just their personality.
Probably, which might need some attention too, but, it's not necessarily mental health related.
Right.
But if somebody has been a calm person and all of a sudden they're having angry outbursts,
right?
Yeah, you've got to pay attention. Something is happening for them. But generally for depression, you will experience lack of pleasure in activities that you would otherwise enjoy. Very low energy, inability to even get out of bed, right? Changes in appetite, you either start to eat too much or very little, or very sporadic, that one day you'll eat a lot and then a couple of days you won't eat at all. Sleeping patterns are like that also. Right?
And then like aches and pains as well.
Yes.
And I think that we've sort of grown up with older relatives who always had a headache or just always felt tired.
Absolutely.
I think there was just so much undiagnosed depression just kind of floating through generations.
Exactly. And now the generation that comes to therapy has a lot to tell about the generation before and how they were suffering. And they were never seen. You know, so I think you're very right about it. It's so undiagnosed.
Which is important because I think that it's something that has existed amongst us for a long time. It's just that we didn't know what it was. We sort of didn't understand what it was. And it was just something that happened.
Most of the people who come to therapy just tell me how unhappy their moms were. You know, mostly. And I was like, oh God, this is a huge number of women in that generation who weren't happy. Right?
And it's actually very common. In fact, it's almost like expected that you will have older female relatives who are just like, this is rubbish. You know, everything was rubbish. And I feel like, again, maybe that's a cultural thing where women at least are able to express their sadness or their frustrations or their disappointments. But a lot of men don't.
No, they have difficulty.
But do you feel like there's a difference between maybe Pakistani cultural sort of approaches to processing emotions and maybe like in other cultures, because you do straddle both? Do you feel like there's a difference? Are we able?
Definitely. I think that like if we focus on just the idea of suicidality, in the US, it's like mental illness plays a huge part in someone experiencing suicidality. In Pakistan, it's different. It's more about interpersonal relationships, financial concerns, cultural context, marriage concerns. You know, am I someone who will be able to get married, or will that not happen ever for me? Financial concerns is huge too. A lot of people who have like significant debt or have a lot of things on their plate and they're struggling to take care of their family, they're also more likely to experience like suicidal ideation. So I think the way our culture perceives mental health is so different. The way we conceptualize mental health is so different compared to how it's perceived in Western countries, because we have additional layers, complex layers of what's adding to our mental illness. And something that Maryam mentioned, which was an important point about how that person may be more irritable, withdrawn, angry. Another thing is when a person has a plan, when they have decided that this is something that I'm going to do, you will notice a sudden switch in behavior where they'll suddenly become extremely calm and relaxed, almost like they're at peace. And that is when you notice that, okay, if this person has been complaining about life sucks, everything sucks, and you know, my life has just not been going well, when is it ever going to get better? And then suddenly you notice this very quick switch to being extremely calm, very peaceful, almost like they're in this like euphoric state and just very relaxed. That is also troublesome, because they could indicate that they have developed some sort of plan in their mind of how they're going to end up doing it. So unusual behavior is something to pick up on.
Which goes either way. Can be sort of frustrated, irritable, angry, or it can just be like extremely, weirdly, strangely, just calm. So we were talking about suicidal ideation earlier as well. So it is normal to have thoughts of it. But there's also a sort of further differentiation in that as well, where there's a sort of passive approach and then there's a kind of active approach to it. So could you tell me a little bit more about that?
Yes. So it is all right to contemplate it sometimes, you know, because when you get so frustrated and you're so tired, you want to just, you know, sleep forever kind of a state, right? And we can all relate to that. But to not come out of that state is a problem. And then when you can actively contemplate that this is how I'm going to do it, or you start self-harming, you start to self-harm, right?
So what comes under self-harm?
Self-harm is, cutting yourself, right? Burning, inflicting some form of pain to your physical self.
Right. Substance abuse, is that also?
Substance abuse, not so much.
Okay.
It is a destructive thing, sure. But when we talk about actively self-harming, that is more about harming your body actively, right? So this could also be related to suicidality, because, self-harm is another topic altogether too. It exists on its own without suicidality, and it is also a learned behavior. So kids learn it from each other because it very quickly elevates their psychological distress. When you physically cut yourself, your psychological pain for that time kind of subsides.
Because the sort of physical pain of it kind of overrides
the psychological pain. And the rush that body feels with it, it becomes addictive. So that's why it's another topic, but it can happen with suicidality also, that you actively start to contemplate, and then you might have the tendency to self-harm also. Taking a lot of pills, attempted suicides, smaller attempts, which will not go through, but you will still do them. So that is active versus passive, when you're just
thinking about it and not really doing anything about it, but just having these kind of private thoughts.
Right.
But these like minor attempts and self-harm are sort of a more active approach.
Yes.
Okay, we're going to take a very quick break, and I want to talk to you more about that. Stay with us. We'll be back in a minute. Hi, welcome back to the coffee table. We're talking to therapists Fatima, Hashmi and Maryam Suheyl about mental health and suicide on the show today. So before the break, Maryam, we were talking about sort of active versus passive ideation, and how small attempts to sort of try and sort of small suicide attempts are also a way of A, testing the waters, but also B, do you think that it's actually like a cry for help? It's actually sort of on one level you want somebody to notice and to step in?
Yes, absolutely. Because as I said initially, there's very little space for them to talk about how they feel. They might as well do something to let everybody else know how they feel, right? Because probably the system is not picking up the cues of distress.
Yes.
So then something really has to shake the system, right? And everybody then starts to worry about that person, which is not manipulation. Oftentimes when we talk about, it's a cry for help, we are actually meaning to say that, it was manipulation.
Or attention-seeking behavior.
What really is that? Give them attention then. If it can save them some distress, give them some attention.
It shouldn't be such a big deal to pay attention to somebody if they need it.
Exactly. And they're saying that in so many words and in so many ways, right? So attend to them. They don't have to go through something like this to let them know, or to get your attention, or the family members, or the system's attention, right?
And I think that, Fatima, you mentioned students as well. And do you think that there's any kind of particular age bracket that is more susceptible to suicidal ideations and thoughts? Or is it just, you can't really say, it just is?
Yes. So, the very minimal studies we have on South Asia, unfortunately, have highlighted that between the ages of 15 and 29 is typically where a lot of that younger generation is typically the one that usually thinks about suicidality pretty frequently and also acts on it. And academic pressure in Pakistan has been cited as one of the bigger reasons for individuals of that population. So, it's not uncommon to hear that in universities or in schools, some child did end up committing suicide, because that pressure just felt so immense that they felt like they had no other option, and that was their only way out. older generation does it too, but I feel like it is more prevalent in that said age bracket.
And I think it's true statistically that more females think about it, but more men actually do it, which I also significant.
So it's interesting because I think women attempt just as much as men do, but the reality is that men end up taking it to completion.
Oh gosh.
So
they're more successful.
Yes, they're more successful at completing suicide. So it's not that the attempt is any less with either gender. It's just that men end up taking it to end up completing the act of suicide, more likely. There was a ratio given that, in cities like Lahore and Karachi, Larkana, that there is an incidence of higher suicide attempt by males than women. And I think the ratio was about 1.5 to 1.
Okay, which is
in some of these cities.
Which is a huge difference.
Yeah.
So
it's not like a significant one. Yeah.
No. Yeah. So a lot of times, I think, again, sort of cycling back to Pakistani culture, and I'm sure this is true actually around the world, is that a lot of times, and this age bracket that you mentioned, Fatima, is also the age bracket where you are going through a lot of, adolescence is a really difficult time.
Absolutely.
Your early 20s is a difficult time. And what could be a cry for help can very easily be misinterpreted as just being a teenager, just being a difficult young person. A kind of stereotypical thing where nobody really realizes what was actually, going on underneath the surface.
Yeah, and that's where a lack of compassion really plays a part, because we are so dismissive of anybody who shows any signs of vulnerability.
That's true.
Right? So that we just want to, write it out as, it's just them being teenagers, sensitive or they'll grow out of it. Which probably they do, but right now you just don't have to wait for them to get out of it. You need to actively be there, right?
And do you think that a lot of times, and again, we talked about this in the first segment, that getting therapy is an expensive thing. It's something that's not accessible for a lot of people. So a lot of times people will turn to friends or family members to talk about how they're feeling. Now, obviously, a friend or a cousin is not qualified to help, but at the same time, it happens to so many of us that we will have somebody who we love and care about who is going through a difficult time. So how can somebody like that, who in that position, how can they help?
First of all, really openly helping them talk about it, whatever they're going through, that does help, and then finding right resources for them, and I generally think that if you can offer some kind of compassion to the person who is suffering, they do feel better. You don't have to be a therapist. You don't have to be trained in that, right? Because what you're actually speaking to is the human quality, the human which is suffering inside, and they respond to compassion. They respond to when they feel heard, right? So there's if somebody goes to their friend and they're like, oh, I'm feeling that way, and they're like, oh, all right, let's just go have some coffee. This is not going to help them, right? So the person who's listening, who's been approached, then needs to really take some time and allow the person who's suffering to come out with everything and learn to just pay attention. Right.
So what's a good way to respond to sort of, what are some words one could use, for example?
I think Fatima could be a better...
yes, Fatima, tell me.
Clinically there,
What are kind of some ways that, a layperson, some kind of maybe phrases or ways that you can sort of approach a conversation like that? Because I think a lot of the times one feels kind of stunned by this information and you don't know what to say
I think though the key thing to remember here is that you as a friend, as a family member, don't feel like you have to therapize this person. Don't feel like you have to sit in the therapist chair and then start giving them therapy. It's nothing like that. You're just providing that initial intervention of support that is then going to lead them to more resources. And how you can do that is through empathic language. So one thing that really minimizes someone's experience is saying something like, don't worry, you'll get better. Don't worry, it'll be okay. Just get over it. Like this happens to everyone. Also, our older generation, like bless them, are extremely resilient human beings who overcame a lot. But what they don't understand is the younger generation is actually holding on to their trauma and the predecessor's trauma. And we're holding on to a lot of trauma and facing a lot of it right now. So the language with which we approach them is very crucial. So saying things like, I may not understand what you're going through. I can't maybe even imagine what you're going through, but I want to. I want to know. I want to understand so I can connect you with the right people. And oftentimes when you approach people who are experiencing suicidality, you'll be like, how are you doing? I'm noticing you're kind of down. They'll be like, I'm fine. I'm okay. Like, don't worry, I'm fine. Like explore that more. Don't be scared to explore that with them more. Be like, I kind of feel like you're not fine though. I kind of feel like maybe something's going on or I'm noticing some things. So don't be afraid to take that conversation a bit deeper because honestly, they just want someone to listen empathically to what they're going through. They just want someone to sit there and just hear them out. And that is the best thing that you can do. And then to take it a step further, if they're disclosing that they have a plan, if they're telling you something like, this is how I'm planning to harm myself, as a family member, as a friend, make sure to keep some of those items that they might use completely away from them. Lock it up, hide it, take it away if they're thinking of using some sort of weapon, or if they're thinking of doing some sort of, make sure that you take that out of their reach so they don't even have access to like that.
So it is important to kind of have that kind of intervention as well, where you're kind of physically taking away harmful things from them.
So Fatima, I was wondering because with our intervention, when we do suicidal assessment, our process stops there, right? Because in Pakistan, we don't go any further because there are not systems in place to address that problem, and then we start to rely on the family, right? We ask the family members, okay, these are things you can do, or these are things you should do, and maybe look for this resource, that resource. But I just want to understand what has helped as a system in wherever you are working, and how efficient is it when it comes to suicide assessment and ideation and prevention?
Yeah, so that's a very good question. So studies have shown that hotlines are actually extremely beneficial because people typically don't want to identify themselves and say, I'm experiencing this, and want their face on the surface of anything. So maintaining anonymity and being anonymous is extremely crucial for a lot of these individuals. So having some form of, especially for the younger generation, having some form of online chat room with experienced, trained individuals who can provide support to them, having hotlines with individuals who are trained and can provide support to them. What typically happens in the United States is there's an infrastructure where if an individual has identified an immediate risk, they are hospitalized for a week. They're seen by psychiatrists, they're seen by psychologists on the team. And once the assessments are complete, once they deem it okay for that person to then leave the hospital and they are no longer under immediate risk, then they are allowed to leave. But they're also told that they have to keep coming back for one-on-one individual sessions. So there is like a chain, a process that happens in order to make sure that there's accountability.
Yeah, no, and I think that kind of system is really important to be able to have here.
Absolutely.
Because a lot of families can't cope with that responsibility.
They can't, absolutely. And this sounds easy. It isn't that difficult. We do have hospitals. We do have psychiatric wards, right? We just need to have that system that connects, the individual to the system where they're taken care of, because they're unable to. When there's an immediate risk of suicide, then they're unable to take care of themselves, and the system has to step in, right?
Yeah.
So I think hospitalization is something that the families should also consider. They're reluctant to do that.
Of course, because it kind of goes back to those initial fears and taboos about the whole process.
But in that moment, what takes precedence is the safety of the family member, right?
Like nothing is more important than loved ones.
A hospital has that system, a night watch, they can actually take care of that. It just needs to be streamlined. It is not that difficult. We do have hotlines working here in Pakistan. The awareness, right? And because I feel the more we speak about it, like Corona, right? We were telling people, wash your hands, wear a mask, wash your hands, right? Why can't we do that with mental health?
Absolutely.
When you start feeling, just dial this number, okay? Before you think of doing something, just reach out.
Quite right. And I think that the anonymity that Fatima talked about was also really important, especially for here, because it's already such a big deal to talk about it.
Absolutely.
But you don't want to put your name to it either,
And also, a lot of times it happens at an odd hour. You can't find a therapist at like 2 a.m., right? But you can reach out to a hotline.
Yeah. So there is help. It's just that we need to be able to find it. And thank you so much, Maryam. Thank you so much, Fatima, for being on the show with me today. This was a really, really important conversation, one that we need to keep having. If you're watching this on YouTube, don't forget to like and subscribe. Please share this. Watch it with people who you think it might help. Stay safe. There is help out there, and you're not alone. Thank you for watching, and we'll see you next time on The Coffee Table. Bye now.